It's a difficult task to do it within 10 minutes, but I'll try. Uh, so I'm just going to give a clinical scenario. Mr. D, a 45-year-old male, has been diagnosed with ALS, has been started on Riluzole recently. On review, the patient and wife would like to know more about the pharmacological therapies in view of the prognosis of the disease itself. So what evidence is there to start on for disease-modifying therapy in ALS? So for this case scenario, I've chosen this guideline, European Academy of Neurology's guideline, in collaboration with the ERN and the EuroNMD, which has been published in European Journal of Neurology. So I'll be doing this appraisal with the tool called Agree2 tool. So Agree2 tool, just a little bit about Agree2 tool. It can be used by a lot of people. Who can use it is like healthcare providers like us, developers who want to do new guidelines adapting to the old guidelines. Like India can do a guidelines based on the European guidelines, so those people can use it. Policymakers like at the government level who want to implement it in the government hospitals. Educators, again, like this, where we want to enhance our critical skills, we can use this Agree tool to teach. So Agree2 tool is a very elaborate tool. I will not get into it here, but as we go through, you will understand each domain as what it means. So the first domain is going to be scope and purpose of the guideline itself. So for this, there are multiple questions under each domain. So for the first question, the overall objective, is it specifically described? I agree strongly to it because they have mentioned ALS is just not about neurology, it's a lot about more of rehabilitation and multidisciplinary care, which they have specifically described as to what are all the objectives of this guideline, which the guideline means to achieve. So the next question is, are there specific questions which are mentioned in the guideline? So they have given a brief domain of disease modifying therapy, service delivery, and multidisciplinary care and management of symptoms, as in like it's very detailed, as you can see here. And they've given detailed research questions for individual domains, which are 9, including end of life. So that was pretty much elaborate. So for the next question, where the patients and public specifically described, this has been mentioned, it is applicable to all ALS patients and any healthcare professional who is dealing with treatment of ALS. So again, it has been specifically described who it can be used for and by. So stakeholder involvement is just about who has developed the guideline, how did they develop, was it properly done, was it targeted appropriately. For that scenario, like the question next is, did it include individuals from all professional groups? A guideline is not by single person, it's always by group of people. How did they do it? So for that, they have had 17 group members. This is the European Association of Neurology. So they have had multiple people from all over Europe who are neurologists, neuromuscular disease specialists, ALS specialists, and researchers. They had 2 people from Cochrane Response for the methodology and support. But what I thought they could have included pulmonary medicine specialists, psychiatrists, psychologists, and physiotherapists who are also involved in a lot of ALS care because of the prognosis and the other non-neurological symptoms they present with. So the views and preferences of the target population have been sought. So usually whenever a guideline is done, it is always presented with the patient representative who can give their input, as in from their perspective as to what do they want from this guideline, what do they expect as an improvement in them, what do they expect in life with this disease. So they had included one patient, but the level of disease of the patient and probably 2 more or 3 more patients who could have been at different levels of the disease could have added more a value to the guideline is what I thought. So target users, again, I said all healthcare professionals, it was appropriately mentioned. So the rigor of the development, how did they develop the guideline itself? And even if you're going to do a guideline in the future, this is what you need to do. So how did they go about searching for evidence? So they had 3 levels. They chose the top of the pyramid for the evidence itself. They started off with guideline itself, other guidelines. They had chosen nice guidelines as the only best guideline which they could find, and they have appraised that. They had, which they found from this database. I'm not going to read it out, but they have done an adequate job for systematic reviews and RCT. So they've not included case controls, case series, and they included all studies in all languages, which is also good. So they didn't miss out a lot of studies. So this was a very elaborate keyword search, which is like 2 pages full, 42 keywords. So it was elaborate and I felt it was good. The criteria for selecting the evidence were it described. So yes, so they had individually mentioned about PICO statements, which they, like I'm giving you an example for one of the domain where for pharmacological therapies, they listed out the PICO statement and then searched for it in evidence so that they could find adequate records. And with that, they had found almost more than 9,000 records, of which they have excluded 9,766 due to duplicates, PICO mismatch, not an RCT, not the appropriate study, and they have come to the final end. So they did an identification screening, check for the eligibility, and then went into the evidence itself. The strength and limitation of the body of each of the evidence were it clearly described. The strength and limitations were there, but it was not clearly described. I could not find it very easily. There was just each study's PICO statement, a little bit about the outcomes of the statement, outcomes of the studies, and I had to go into the individual papers. Results to find out about the serious adverse events, the effects, and everything. So it was not very clearly described in the guideline itself. So this is just another, I'm just putting up a slide about how to qualify grades of evidence. Here it says high, moderate, very low. You can see here also where the moderate evidence and all those have been given on that side. This is how they grade the evidence individually for each study before putting it into a guideline. And they can downgrade the levels as per this based on the table point 5.2, where they say limitations in each of the study design results, imprecision, and publication bias. Likewise, they had good grade of evidence for most of the studies which they picked. So the methods for formulating the recommendation, once they get the evidence in, how do they formulate the recommendations based on those evidence? Because it's multiple evidence. How did they do it? Because it can't be one person doing it. So I've just copied the entire thing, recommendation, how would they adopt it? I've just highlighted in red to just show how they did it. For the recommendation for the NICE guidelines, a lot of it they just adapted directly from the NICE recommendations itself. Other guidelines which were not there in the NICE guidelines, they did something called evidence to decision framework, which is they found out what are the evidences, they sat together and appraised the evidence, then they sat together again to come to a consensus at a meeting. As I mentioned in the last slide, they've done informal consensus process where like this a patient group of all the 17 members would be there and they would vote or not vote for individual recommendations. I thought that was fine, but except for just consensual voting might not be the great idea because there might be mismatch. Someone who's doing research in that area might be inclined towards saying that this might be better. So I'm just going to show this is just about health benefit side effects have been considered in formulating the recommendations. Yes, but I could not find the side effects of individual pharmacological therapy in the guideline as to why you should not use it. So I could find results of say this is riluzole. Just giving an example, which they had mentioned about the studies effectiveness in the supplementary, which I could find, and the adverse events, which gave us about the adverse events individually. But when I'm looking at tofersen, as Sir said that this is a new drug which has been approved by FDA, I could not find individual serious adverse events. And the serious adverse events, when I looked for in the individual RCTs, said that they can have myelitis, they can have aseptic meningitis, ICT, which was not mentioned in the guideline, which I found it was not right. There's an explicit link between the recommendations and the supporting evidence. Yes, individually they have mentioned evidence for rational for the recommendation for individual recommendation they did, so that was adequately done. So other than that, even every time we know that whenever a study comes out, it has to be peer reviewed by someone, which was not done in this paper, or it was not mentioned in the guideline either. So that was a big drawback. A procedure for updating the guideline. Any guideline again would not be valid after a few years because new research would come. So usually a guideline should always say 2 years, 3 years from now on, this guideline will be invalid and there will be an update to this and then we will re-release. But that was not done. And this was a guideline done in 2023, while the previous guideline was 2012, almost 11 years of gap, which was not great. And they have not mentioned as to what they plan to do further on either. So clarity of presentation of the guideline itself. So there are multiple statements for the probably everyone knows the strong, weak, and recommendations. Likewise, they've done for disease modifying therapy individually. I'm just going to go into tofersen, which they've said strong recommendation to be used in SOD1, which is superoxide dismutase in mutations, and there are some adverse events. They didn't mention what that was in the guideline. So the different options were mentioned, key recommendations were identifiable, while applicability wise, there were facilitators and barriers, but it was not very clearly mentioned is what I thought. Where there provides advice and a tool, like an algorithm where you can say like, this is what you do for this patient, this group, that was not mentioned, but you had to read through the whole guideline and understand yourself, which was a little tedious. Resource implication, they did not mention how much resources were spent or who spent it. Auditing, what is auditing? Guideline, once it's released, you have to make sure the guideline is actually working well. You audit and say like, okay, this guideline is working so much, it's helping this many people, and audit and see how the guideline fared, which was not mentioned, and how they are going to do it was not mentioned. Editorial independence wise funding body, there is not no mention about finance, but the associations have done it, and there were two people who were from the association. So was there an influence? I was not sure, so I graded it 6. So competing interests, they have done it in detail. So finally, at the end, an agreed to guideline critical appraisal, this is what you'll get. You will score it such that, and you can always go and individually do the percentages for each of the domain, and that is how it comes to. And the overall percentage of the agreed to score was around 72%, which is optimal. So overall guideline assessment, I thought it is a good guideline, but except for few things which could be modified. So coming back to my scenario, in this patient, would I use Tafacin? As per this, I would say that you need to go for mutational testing for SOD1, and then if they're okay with the implications, because Tafacin is given intrathecally, there are a lot of side effects, the regularity of coming into the OPD and all those. If they are willing to be okay with that, I will go ahead with that. Thank you.